This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hello and welcome to another episode of It's Not In Your Head. I'm Justine Feitelson here with, as always, Dan Bates. Hello.
Hey, Juz. How are you?
Good. Doing well. I'm in a different uniform today, but...
You are?
I know. Still the brand colors. It's all right. Recognizable. Okay. So don't surprise everybody. It's in the laundry. All right. So today we are going to get into the opposite end of the spectrum compared to what we've been talking about on recent episodes, where we dove deep into the conservative management strategies for widespread, more sensitization related type of pain. And now we're going to swing over to the other end of the therapeutic end of the spectrum and focus on procedures and interventions that address typically and ideally more focal physical drivers of pain, not as much related to the amplification and nervous system dysfunction pieces of things. So it's going to be lighter work for me, more for Dan. And he's going to take us through a lot of what he does when he's trying to narrow down and further figure out what is driving and causing somebody's pain, especially when it is or has previously been diagnosed as nonspecific or struggling to find that specific cause.
Yeah. So what we're doing here is we're going to talk through a range of techniques. We're going to split this into a couple of podcasts, probably a number actually, just to sort of split up different procedures so you can sort of listen to things quickly if you're doing something. And the whole idea is you are moving from a point in time where you've been diagnosed with something like non-specific lower back pain. That takes place because history examinations and imaging findings are not very good at narrowing down what the underlying cause of the pain is. So it gets labeled as non-specific, but also then you get non-specific treatment. And so, right. You can imagine treating, one problem like a sacroiliac joint versus a facet or a disc in a back. You treat them with the same thing. Surprise, surprise, you don't get the same result. So right. The whole idea is we're trying to identify here what is the right treatment for the right patient. And so we do that with a series of move through what is known as diagnostic blocks and then into the therapeutic intervention itself. We're going to talk about lower back pain first, but we'll talk about the blocks in a little bit more of a broader setting because we're talking about facet joints or facet joints you find in necks, thoracic, lumbar spine.
Different areas.
And the diagnostic process is the same. So lower back, we'll start with first. So when you're going from non-specific to specific diagnosis of lower back pain, what you've got is you've got 5 major causes. So you've got facet joints, sacroiliac joints, hips, discs, and nerves. You will have heard me say this before. As a rule of thumb, to try and work it out, if it's worse in your legs and your back, start at nerves first. If it's worse in your back, split your back up. So if it's above the belt line, start at facet and disc. If it's below your belt line, start at sacroiliac joints and hips. Of those 5 causes, so if you look at the diagnostic block data, so facet joints is 15 to 40% of presentations. Sacroiliac joint arises in 10 to 20% of patients. Hip joint causes 5 to 10% of back pain. That's important to note. Juz was asking about that before.
It's like, how can it only be 5 to 10%? Yeah. It's like that, just a back pain.
Yeah. Discs cause 16 to 20% of pain, and then nerves, so nerve with leg pain at the same time, so back and leg pain causes 12 to 40% of pain. So
and these we also covered in the managing the low back pain episode. So for a deeper dive into like how these present and what are signs of the different types of back pain, if you're trying to tease that out, look at that one as well, because it ties into the presentation and then drawing this effectively.
Yeah. So the first one we'll talk about in the first diagnostic block we'll talk about in this episode is called a medial branch block. Now, there are 2 ways to go about diagnosing facet joint pain, and first one is a medial branch block, and the other one, which you would think is more logical, is a facet joint injection. And so everyone just says, why don't I just get a facet joint injection? So the reason why we, especially I and many of my colleagues, don't really do many facet joint injections is because the facet only holds a very, very small volume of fluid. Okay. And so if you look at how a procedure is done commonly, you'll have an injection that has 2, 3, 4, 5 mils of fluid. Of that, most of it is local anesthetic. So the facet joint itself will hold in the lower back about 0.8 of a mil. So if you put in 0.8 of a mil of your mix of local anesthetic plus or minus some cortisone, after then everything else spreads everywhere. So it's not spreading into like an empty space. You're not like getting a little globule of 5 minutes. What happens
then it stays there.
Yeah, it's like injecting a piece of steak, and it just kind of goes everywhere throughout. It spreads everywhere. And so what ends up happening,
leaks out of that space because the space can't hold it, so it just goes around it. Okay.
So you end up blocking a large number of structures because you push in so much fluid. And this is what happens. And so where people will go, yes, I had a great response from that facet joint injection. It's possibly the facet joint. It's also possible that it's, one of the other multiple things in the area that have been blocked. So
from a diagnostic block perspective, that one's actually
it's not really useful. If you get a facet joint injection and your pain goes away and it stays away, who cares? If it was the diagnosis, great. If it wasn't the diagnosis, it doesn't matter. Pain's gone. So
that makes sense though.
But in this setting, we're using a medial branch block. So the medial branch is a little nerve that comes off what's called the dorsal ramus, which is essentially just technical terms, and it supplies the facet joint. And what you're trying to do here is you are trying to block the nerve supply to the joint. The reason why we're doing that is that the next step is to go on and then heat that nerve supply up. So you take away the nerve supply, and that's called radiofrequency ablation, and which is the therapeutic technique we go on to do after this.
And if you're doing that technique, you want to be sure you're doing it on the right structure or thing, which this needs to be specific for.
Yes. Yeah. So to do that, what you do is you do it under X-ray guidance, or you do it under CT guidance. And what you're doing is you're placing a very little amount of local anesthetic, about 0.3 of a mil, up to 0.5 of a mil, directly over the medial branch. And what you do first is you place the needle using either an X-ray or a CT. You put in an itty bitty bit of contrast. So the reason why we're using contrast in that setting is you're trying to make sure that, number one, the contrast is going where you expect it to go. And two, you're making sure that you're not actually in a blood vessel. So if you're in a blood vessel, you inject the contrast and there's no contrast, you're going to get a negative block because you inject the local anesthetic, and a lot of local anesthetic disappears off into nowhere. And so you end up with a false positive block. So in this setting, you put in your local anesthetic and you are then going to see if your pain goes away. Now, when we do this, each facet joint has multiple nerve supplies. So it has at least 2 branches, one at the level and one above. Now, because of the way the spinal cord is labeled, the naming of the nerves don't match up with the naming of the facets. So very annoyingly, you would think that you'd think that L5S1 is supplied by L5 and S1 medial branches, but it's not. Okay, it's actually supplied by L4 and L5, and L4's actually on L5 and L5's actually on S1. So it's super confusing, but don't get so concerned if the numbers that the doc says is blocking don't match.
They're doing a good job.
What they said was the facet. They're probably doing it right. So what you do after that is you then give somebody a pain chart. And so that pain chart, you'll record what your pain is beforehand and then what happens over the next 6 to 7 hours. And the most important thing here is your pain will go away and it will also come back again on the same day. Now, I'm going to say that again. The pain will go away and come back on the same day. Now, everybody forgets that. Everyone it doesn't matter how many...
Along with not eating on procedure day.
Yeah. But that's okay. That's okay. We understand what everyone forgets.
It's just
so the pain's going to go away. The pain's going to come back. The question there is, how much does it go away by? Now, how much it goes away by will then predict what the likelihood is that you're going to respond to the radiofrequency neurotomy. Okay.
So the more long-lasting version.
Yeah. And this is where things start to get a little bit fuzzy because diagnostic blocks, like everything else in medicine, are not perfect. The response to the medial branch block, what we're looking to see is if 50, 60, 70, 80, 90% of your pain or 100% of your pain goes away. And that then predicts how likely you are to respond to the radio frequency. And so if you have a 50% decrease in pain, there's probably a 50% chance that you're going to respond to the radio frequency neurotomy. As you go up in percentage decrease in pain, so if you have 100% decrease in pain and you do the diagnostic block twice, and twice you get 100% decrease in pain,
So it's
there is
replicable.
then,
Yeah.
based on the literature, 100% chance that at 6 months you'll have close to 100% pain relief. Now, that varies depending on which literature you look at. So one option for us to do is we can do 2 diagnostic blocks. You do 1 block with short-acting local anesthetic and 1 block with long-acting local anesthetic. If you do that process, there's kind of the 60-90 rule. So if you had a short-term response with the short-term block and a long-term response with a long-term block, I sort of see it 60-90. So there's a 60% chance you get a 90% decrease in pain, and there's a 90% chance you get a 60% decrease in pain. It's those sort of approaches that we're looking for. I think that the practical way that I approach this is that if you get a 50% decrease in your pain when we do a diagnostic block, there's probably something else causing the pain.
A different cause as well. So
so there's something else going on.
Yeah.
So in that setting, what we will do is we'll be asking, did you feel the pain was a bit higher? Did you feel the pain was a bit lower? I will then go on and repeat that block and then add in a level above, add in a level below, and we see if we can get an improvement in that. So we get better coverage of the patient's pain with it, and we go through a double block process. If alternatively your pain goes from 8 down to 2, we've got an 80% decrease in pain, it's on a single block, you feel very comfortable, the pain's decreased, I'm comfortable, the pain's decreased, so I'll go straight to a radio frequency after that. And I think that's the most practical way of working through the process. So we do the diagnostic block. We're going to ask patients to fill the pain chart out afterwards. We're then going to follow you up. So follow up with myself after a diagnostic block is generally with my nursing staff. You'll speak to them on the phone. They have the plan already laid out, and they will then say, great, this is what's taken place. If it doesn't follow the plan, it's then either a review with myself or the nurse discusses it with me and I say, okay, we're going to do this. And which is commonly, let's do another block or add something in, add something below. And we go through.
Yeah.
With any procedure, there's always a bunch of risks. So there's a risk of infection. There's a risk you get a bruise. There's a risk you get a flare of pain afterwards. So for the patient that is very sensitized.
This is my story of, I had 6 medial branch blocks done at once and it was terrible. It's always like, any block would have done it. I'm like, I know, but it was still terrible.
So
even one. Yeah.
So here's the thing. So as Juz just highlighted, there is a subset of patients that will get a worsening of their pain after the injection. Now, that is not because the doctor's put the needle in the right spot or there's been a complication. It's because the patient's nervous system is super sensitized, and it's the
disproportionate response to
it's the disproportionate response to the needle that causes the pain after. Now, that in itself is useful because what it actually tells me is that the patient's really, really sensitized. Don't try and find the underlying pain driver. Let's treat the sensitization first. Shrink down the pain, decrease its intensity, then we can potentially circle back and look at a medial branch block.
And this is the perfect context, to understand that order, because the block is not useful if you can't evaluate its effectiveness or how your pain went up or down because you're just blown up in a bigger ball of pain. So then it's not so useful.
Now, what is useful is if the pain doesn't go away. So let's say you're in a situation where we do the diagnostic block and the pain doesn't go away. What that does is that excludes it as a cause of your pain, which although, it's good if, it's frustrating, pain didn't go away, but the information is still useful because it then means you move on to the next diagnostic
You've eliminated a cause. And it's not that you ended up in worse pain, you just didn't get better. So you're not in sensitization land.
So facet joints, as we already said, are present in your neck, in your thoracic spine, and in your lumbar spine. The technique to diagnose facet joint pain is the same in each level. So if you appear to have facet joint pain, we go on, we do a diagnostic block. You may do one block, you may do two blocks, depending on the response to the first one. And then you go on to do radiofrequency neuronomy. And so that is how you work out facet joint pain.
Excellent. Good overview, Dan. Thanks.
All right.
Perfect. I don't have a lot to add to that.
Oh, yeah. There you go.
It's well done. All right.
All right.
Oh, and reference, like we talked about, if you're someone who's trying to work out your back pain, go back to the managing low back pain episode, and in particular, how to draw your pain, because that also correlates with the procedures that we're talking through. So that'll give you some underlying knowledge.
All right. Very
Perfect.
good.
All right. Thanks, guys.
Okay. Thanks, Joss.
See you on another episode if it's not in your head.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.